Good morning to this morning's, and welcome to this morning's session. Our speaker coming up is Roger Kerry. He's a chartered physiotherapist and associate professor in the Division of Physiotherapy and Rehabilitation Sciences at the University of Nottingham. In 2011, Roger was made an honorary fellow of the UK Musculoskeletal Association of Chartered Physiotherapists. He has a clinical interest in research interest in predominantly vascular dysfunction related to physiotherapy, but also specifically for the cervical spine. Over the last decade, he has published over 30 peer-reviewed papers and numerous book chapters on this topic. Roger is also the co-author of the IFOMPT cervical framework, and his research or his doctoral studies are concerned with understanding the nature and causation of evidence-based medicine. So please welcome Roger Kerry.
Morning. I've got some sweets. You have to vote. Do you have to vote if this is a good talk or not? There you go. Got some beer mats. There you go. That's worth a few. Oh, badges? Got a badge? You want real beer? Yeah. There you go. Got. There. There's some change. Got kazoo. No falling asleep. That's for if you fall asleep. Oh, and I've got a talk as well. Let's do vascular system. This is 40 minutes of a story, really. And it's a story about the vascular system. It's a story about the role of differential diagnosis and our position as physiotherapists within that. And there's sort of three strands to the story, but I'll emphasize the big one, which is the sort of clinical story, with some examples about the sort of stuff we're talking about and the sort of clinical patterns. But there's also a background story of the last 20 years and sort of what's happened in terms of education and practice and research with this. And then there's a sort of third story about why it's taken so long for something which you'll see, and you probably know anyway, is a fairly simple concept. It's just, there's nothing controversial about the sort of stuff we're talking about here. And it's like, sort of, why is it taken so long for a profession to respond to some, a robustly supported evidence-based package of stuff, and we're still sort of dealing with where that fits in education and practice. So think about those sort of three things. I'm not going to go on and on about sort of implementation, science, or knowledge transfer or anything like that, but just think about why something's taken so long. So we call it a triple helical story. Oh, and just by chance, the vertebral artery has a helicoidal flow, which keeps it nice and clean, which is why we don't get too many problems with the vertebral artery. The story's not about me, really. So if there was anyone physiotherapist it is about, it's a chap called Alan Taylor, who sat just there in a scarf in summer. So I'm going to put up some papers and references from quite a while ago to sort of exaggerate this point of this conversation was happening 20 years ago, and it's sort of the same conversation. And this was one of the first papers that Alan published in Physiotherapy. I think it was as an editorial, just suggesting that the vascular system is something we should be aware of as manual therapists and physiotherapists. And I left this bit of the abstract up here on this slide to talk about fast becoming an essential tool. So this was in 2001, and Alan and we thought it was fast becoming an essential tool in practice. And now in 2016, we're still sort of saying the same thing. We think it's becoming a tool. So again, it's sort of why isn't it a firm part of our education? So it's quite relevant, really. The Tour de France is on at the moment. The story here, so I'm going to frame the story in relation to where Alan started and where I came in. And really, one obvious starting point for us as clinicians was with elite cyclists and professional cyclists. Now, this isn't about. I'm not going to say vascular problems are the sole province of elite athletes, but they serve as a really good model for understanding the types of pathology we see in the differential diagnosis. And then we can relate that model to non-athlete patients quite nicely. But professional cyclists are good because they offer a package of the model, which is really clear to see. Because what we're talking about is, the question is why would physiotherapists see people with vascular dysfunction? Well, the link is that some subgroups of patients with particular types of vascular dysfunction present with pain being the only manifestation of that pathology. So the headache and neck pain thing is the example we'll regularly talk about when we're talking about cervical arterial dysfunction, but it's the same in other parts of the body. So if you think about cycling, we're talking about exercise-induced leg pain. And as physiotherapists, we might naturally say, okay, so that's a biomechanical phenomenon. We look at the biomechanics, and that's fine, because that's what we do. But we should also think of it not being just a biomechanical phenomenon, but one of exertion as well. So cyclists do two things: they move, and they also, they exert themselves to move. And within the assessment, we need to think about separating that exertion component away from the biomechanics. So they're related, of course, but in terms of differential diagnosis, we ask, why has this guy got leg pain when he rides a bike? Is that because of the biomechanics, or is it because of the exertion? And there was a particular pathology that was identified a decade or so earlier than this paper here by vascular surgeons working with professional cyclists in France, which is referred to as endofibrosis. And that gives us a clue to the type of pathologies that exist. So endofibrosis is simply a scarring of the inside of a vessel, the intima of the vessel. So it's not systemically pathological. We're not talking about atherosclerosis in this case, but it's a really good clue to see how the hemodynamics, the changes of blood flow within a vessel, can result in a localized discrete pathology whose manifestation initially is pain, and that can be somatic pain, not ischemic pain. So the initial presentation can be somatic pain. It hurts when I move my hip. And then later we can get signs of ischemic pain, like pain in the foot or pain in the leg or something like that. So endofibrosis of the external iliac artery is a discrete pathological phenomena that's easily recognizable in some subgroups of people. So Alan's study here was looking at a comparison of cyclists with exercise-induced leg pain to see how many of those had a vascular phenomena, and there was a significant proportion of them. That's Alan. He used to ride a bike in the 1920s. And that's probably not his iliac artery, but it's somebody else's. But again, this is a really nice picture. So this is an image taken in hip flexion, and you can see the external iliac artery. And there are features like this, these little kinks on the concave surface, and they create a stenotic lesion to the blood flow, so we get less blood in the leg because of the biomechanics. Again, all I'm trying to do is demonstrate the relationship between biomechanics and movement and flow issues. And things like this do present diagnostic challenges to not only us, but to vascular surgeons and medics as well. And if you saw an image like that, in a 65-year-old patient with some mild claudication problems. Nobody would worry too much about that. That stenotic lesion there is not significant. But if that's in somebody who's active or tries to be active, that degree of stenosis is a significant finding, and there's some really good data, normative data and pathological data to back this up. And this is an endofibrotic lesion. It's a scarring of the blood vessel, which is asymmetrical, and a result of the turbulence of the blood flowing through it. So then when this guy tries to exercise, there's a flow restriction which manifests in exercise-induced pain. The endofibrosis as a pathology is exclusive to this vessel, but the model of change to the intima as a result of blood flow is common throughout the body, but then we talk about a different pathology, and then we talk about atherosclerotic lesions. So we can get atherosclerotic lesions in the upper limb, in the aorta, in the neck, as a result of blood flow issue. It's just that the blood flow is very turbulent in the external artery, so you do get this true scarring sensation. This is the popliteal artery that's taken a slightly anomalous course down the back of the leg. It's just shifted out to one side of one of the heads of gastroc, and the heads of gastroc is impinging on this here. So when we go up into plantar flexion, we get a complete occlusion of the popliteal artery. So we get a popliteal artery entrapment. So the manifestation is calf pain or foot pain. Easily, the differential diagnosis is compartment syndrome or something like this. But the point of this is, if we factor in the vascular system in our early pattern recognition, the differential diagnosis, we can start to fairly readily pick these things up. And then furthermore, there are some fairly easy to do clinical tests that we've had this debate for the best part of a decade. Whose responsibility is it to do a test like the ankle brachial pressure index? Well, it's a commonly used medical test. Nurses will do this on diabetic patients and so forth. But with young active people, where we suspect an arterial flow problem to the lower limb, whose responsibility is it? Because it involves, obviously, it involves a component of exercise. So we would test somebody's ABPI and then get them on their bike or the treadmill or whatever activity they do, walking upstairs, going up a ladder, whatever, and then retest quite quickly. So it's an exercise test. Now, there's not a nurse that I know of who would have the motivation or capacity to do that. Neither would there be a GP, neither would there be a vascular surgeon. So really, these exercise vascular tests boil down to the experts in movement and exercise, which is us. So we know all about exercise testing, and as I say, there are a bunch of good tests with good diagnostic utility at our disposal that we can easily implement into practice. By way of example, just move on to the upper limb. And again, the model's the same. We're thinking about which bits of the body move, what's the biomechanics, where are the likely points of impingement of a vessel, how's that manifesting, what the pain pattern's like. And again, the nice clinical challenge for us is that we've got somebody moving their arm, somebody moving the shoulder, and they get pain, and we ask ourselves, is that related to a biomechanical phenomenon or a vascular phenomenon? I'm sort of bypassing the whole sort of pain science story here. Of course, that's a backdrop to all of this, but just reducing it down to biomechanics and vascular. So again, baseball pitchers, throwers, whatever, people who do overhead upper limb activity with some degree of exertion, that needn't be a sports person. That could be somebody in an older age group who stacks shelves at Aldi or wherever. But baseball pitchers have traditionally served as, again, a really good model for understanding upper limb arterial flow problems. And, you know, again, an old reference here, which is typical of, well, as I was doing this, I remembered this. This is how my PowerPoint slides used to look. Back in 2002, we did a short presentation at CSP conference where we did a literature review of studies looking at upper limb arterial flow problems in athletes, and identified about 500 papers and got some really nice information of that, and looked at subgroups and different pathologies. And I'll just go back to that slide, and the point is medics were questioning why physiotherapists weren't identifying these pathologies, and why they were being left, the diagnosis was being left until a critical endpoint. So, shoulder function. Now, I'm going to show you something here. Here's something you may or may not know. King of whiplash, Sir, let me just hover over here. Sir James Elliott used to be I don't know the terminology, a wicket keeper for Chicago United baseball team, or whatever the terms are. And there's Jim doing some, I don't know if Jim's here or not, but there he is doing some baseball throwing, showing some really good biomechanics of the shoulder. Now the thing is, I did mention there needs to be a component of exertion and effort here, which Jim's sort of missing there. Which is probably why he was a wicket keeper, whatever they called it. What is the term, Joe? What's the guy? Catcher. The spine offers some interesting challenges. Back pain, thoracic pain, there's some really obvious things, you know, that look very vascular, look very cardiovascular, look very cardiac. That's the easy stuff. We all know about identifying some stuff, but there are, again, some subgroups of vascular dysfunction in the abdomen and the thorax that can present just with somatic pain. Non-specific back pain, which is worse towards end of range extension and flexion in males in their 60s, you know, is a classical early pattern in about between 40 and 50% of that demographic having abdominal aortic aneurysm. And again, you know, the other 60-odd% is quite obvious. They've got other features, but a sizable proportion will just present with non-specific low back pain. And that presentation, it's not just necessarily for minutes or hours or days or weeks. That can be an ongoing presentation for several months and possibly years as well, before there's further development of the atherosclerotic pathology underlying it, and then things become more obvious. And the next sort of obvious thing down the line for that particular example, a 60-year-old with progressive aortic aneurysm and atherosclerosis, the next bit of manifestation from that is most likely to be either unilateral or bilateral calf pain or foot pain when they walk, particularly if they're exerting themselves again, so when they're going uphill or something. So the pathology has progressed, so now blood isn't getting to the legs as much as it should with effort. And you know, simple vascular tests, even if that's just observation of the abdomen and the legs, or palpation of the abdominal aorta, which is a very easy test, plus or minus auscultation, very high specificity, dependent on the girth of the abdomen and the size of the aorta, etc., etc. But all of the things being equal, there's a fairly quick set of clinical skills that we can utilize, which we is a bit remiss of us if we didn't do that. And again, you know, I know there's issues with screening programs, big, screening programs that are set out throughout a whole region or a country or something. There are problems with that. But screening people individually for a life-threatening condition is, when it's fairly simple and quick with good diagnostic utility, a vast majority of aortic aneurysms are picked up incidentally in patients who go to GPs or nurse clinical specialists with something else, and they're quickly screened because they fit that demographic. Now, that demographic's even more heightened for us as physiotherapists because they come to us with a manifestation of the very thing that's the problem with the back pain. So it's hardly incidental anymore. It is a true diagnostic thing. So we could and should be identifying these a little bit more. And you know, chance findings on plain film imaging. It doesn't need to be a vascular test. I don't know what you see there, but you see a lovely spine, and you start talking about this, that, and that, and oh, look at this thingy here and that thing there. And all the time, there's this massive line of calcified intima here, which is suggesting an aneurysm, which would be, that's sort of way beyond the sort of 5.2 centimetre surgical cutoff point there. And again, these incidental findings are really interesting. Now, competition time. I don't know how good you are at reading images. Some of you may do this all day, every day, some of you may not. But there's another feature here that I wonder if anybody could spot. If you just focus around here, and sometimes it's not easy to see things, so you have to sort of make your eyes a bit blurry or look beyond it or something. But if you see here, and then tell me if there's anything unusual that you see there. Can you see it? It's one of those things that once somebody's pointed it out, it's really obvious. But if you look there, you see a duck. Now, that's really just a bit of a cue for me to get you to have a little stretch. So everybody just to have a stand up 1 second and do a little exercise that I've got for you. So everybody on your feet. Now, this is a bit of a cultural educational experience for everybody. I'm from Nottingham, and there's a common Nottingham saying that we do that I want you to do, and it's A up me duck. So A up means hello. That's why we say hello in Nottingham. A up. A up. So everybody do that bit first. We'll break this down. A up. A up. And then me duck is a term of endearment. So if I, wanted to be endearing to you, I'd say me duck. So I'd say, A up me duck. Okay, now I want everybody to wave your hands in the air, and after 3, the loudest A up me duck you could ever do. 1, 2, 3. A up me duck. That's fantastic. Thank you very much. Now stay stood up because there's still a little thing to do. Now, in the auditorium, this is a bit of a sad story, actually, because we brought with us from Nottingham, we actually brought some ducks with us, and we lost them this morning. They went out of the exhibition hall with no idea where they are. Somebody told us that they saw them coming into here. So somewhere in the room, under some people's seats, there should be some, you might find a duck. So can you have a look on the floor and on your seats to see if you can find a duck? We've got 5 yellow ones, and there's 1 golden duck. If you find one, can you hold it up? Oh, there's one there. One there. One there. 1, 2, 3, 4. Any more ducks? Are any of yours golden? There's still a golden duck missing. Anybody got the duck? Now, if you found one, that's really good news, because you'll see on the label, you get a little prize. So you need to bring that to the University of Nottingham stand in the exhibition hall, and you get a little prize, which is probably just going to be some sweets and a badge or something like that. But even so, you've been there. Thank you very much. That was good. Give yourself a round of applause. So, me ducks. Just a bit of a shameless plug, your duct-based exercise was actively supported by Exercise Works and Physiopedia. And I will point this out to you if anybody's not signed up to this physical activity MOOC. It's just started this week, and you can sign up anytime from now. So that'd be a great thing to get involved in. And it's the first time this is run. It's a massive exercise. It's a massive learning program. So do get involved in that. That's great. Thank you very much. Right. To sort of finish the clinical story, you know, it's obviously worth talking about the neck for a number of reasons. One, it's another example of some clinical patterns. That's fine. So we'll learn something about that. But two, we're at IFOMPT, and you know, the IFOMPT has got a framework document for cervical arterial dysfunction, so we can link the background vascular story in with that. But the third part is also to demonstrate, really, perhaps it's not so much that we've been going wrong for the last 50 years with regards to thinking about adverse events and cervical treatments. You know, we did, for 50, 60 years or so, we did what we thought was best discussing that whole issue of adverse events. But what we can see now is that we can actually approach that same concern that we've got as a profession throughout the world from a slightly different angle. And in my mind, at least, make much better sense of it. Because the stuff we learn from the lower limb and the arm and the abdomen, the model is there. We talk about relative anatomy, where the blood vessels are, movement, what effect movement has on it, and the particular types of pathology. Is this a sort of scarring thing? Is it an atherosclerotic thing? Is it an aneurysm? Is it a dissection? Blah, 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 blah. And we can take that model and just simply apply it to the head and the neck. And as I say, in my mind at least, things then become a lot simpler, more obvious, and also more embedded in what we know from other areas of healthcare practice, you know, like neurology and the vascular domain and ophthalmology and all the other discrete areas that are interested in people who've got slightly strange things going on around their head and neck. And so we can think of the head and that thing that's in the head, the brain thing, as the target organ of the vessels, the arterial vessels that go into there. So where we talked about the calf muscles and the foot being the target organs of the external iliac artery, and where we might talk of the hand being the target organ of the subclavian vessels here, simply the brain is the target organ of the vertebral arteries and the carotid arteries. It's just that the manifestation of ischemia to that organ is a little bit different to the stuff that goes off in the foot and the head. So where we might, in the foot and the hand. So where we might get pain, ischemic pain, and some tingling in the hand or something like that, or some numbness, being suggestive of arterial insufficiency in the hand and the foot. In the head, we just get a slightly extended package of stuff happening, which might be things like visual disturbance or a feeling of unsteadiness, and you know, pain as well, head and neck pain as well, but those are the things. So it's much easier to make sense of arterial insufficiency to the head. We just think of it like, you know, another target organ of the body. And we've got a ready-made package of pathologies to talk about, which we've learnt about from the periphery. So we can still talk about aneurysms and atherosclerosis and dissection events. And, you know, we're going to talk a lot more about this at the Focus Symposium on Friday morning when we go through the CAD framework. So I won't go into too much further detail now, other than to say, you know, if you take something like dissection, we've got concerned about the the idea of dissecting vertebral artery for years and years and years. That's a really rare phenomenon. That's a strange thing to happen. As I sort of quickly alluded to earlier, the vertebral artery is a really cool little vessel. It's designed to do what it does, and what it does is bend and stretch and twist, and it's designed to do that. It's fine. It's really unusual to get a dissection event in the vertebral artery. It's much more common to get an atherosclerotic aneurysm event in the internal carotid artery, and that can, again, in well over, depending on which data you read and what year it is, but it's 2016 now, so the latest sort of epidemiological data about something like internal carotid artery aneurysm would say somewhere between 50 and 60% of anybody with an internal carotid artery aneurysm, their sole presentation, at least for some time of that pathology, will be just neck and head pain and nothing else, because it's the same model as everywhere else. First, you get this somatic pain, nothing to do with ischemic symptoms. Then later on in the pathology, you'll start getting the weird stuff, and of course, things become a bit more obvious that. But there are key times in that pathological timeline when somatic pain is the only manifestation. So again, internal carotid artery aneurysm is a really good example of that. And again, because it's somatic pain, it's of a vascular origin, but the behavior of that pain can look quite, mechanical. Here's a vessel with a discrete patch of disease in it, atherosclerosis, and there's inflammation around that vessel, there's enlargement of that vessel, so the free nerve endings on the outside of the vessel are distended, so it's a candidate source for somatic pain. And then when I stretch that vessel or move it around and compress it, I get a painful response. So facial pain, neck pain, unilateral head pain, when I look up, could be 101 things, and of those 101 things, the one thing it could be is an aneurysm formation in the internal carotid artery. And again, to hammer home the point, that's not what did Lorimer say the other day that he said his daughter said that's not rocket surgery to work that out. It's fairly simple pattern recognition with a fairly simple set of quick diagnostic tools with good diagnostic utility, like palpation of the internal carotid artery plus or minus auscultation, to identify that. Now, of course, there's a big conversation behind that, and some of you sat there going, oh, yeah, but it's this thing about worrying the patient and blah, 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 and all that stuff again. And although I missed it yesterday, the Cord Requiner talk I heard, there was a really good conversation and narrative about that issue, and that can be just superimposed on this. And then we get into a conversation about scope of practice and whose role is this. And that's a valid conversation, and that would be country specific, I guess, to a degree. So I can talk about the UK, and I can guess what's happening in America and Australia. But when we talk about roles of practice and responsibilities, we start to get a really nice conversation going here. And we could frame this into: should we be measuring vital signs at every contact we have with a patient in some broader sense, and does this form a little bit of that or something? But more focused, we can talk about: is it the responsibility and the role and within the scope of practice of any of you as a manual therapist to identify the diagnosis of an internal carotid artery aneurysm? Well, it's just a red flag, and we look out for other red flags, and this isn't, it's not difficult. Just going back to the lumbar spine, the issue is the same. Whose responsibility is it about the lumbar spine? Well, aortic aneurysm is just another red flag. Interestingly, it's epidemiologically, aortic aneurysm is a cause of low back pain is higher than some other of the red flags we look for, but it's seldom stated in low back pain guidelines or documents for practice that it's one we should consider, which is really odd. And you know, any sort of general surgeon or vascular surgeon that we've had contact with thinks it's really odd that physiotherapists aren't primed and preloaded with the information to do such simple, quick clinical tests to pick these things up, and it's not even represented in our profession-specific guidance for things like low back pain in some documents. So, you know, this is what the cervical document was about, to get this message across. And again, we'll reinforce this issue on Friday. But, you know, this isn't a guideline for practice. It's not a algorithmic rule for doing this. It's just casting out what we know from all levels of evidence, ranging from mechanistic type studies up to case studies and some epidemiology, and saying, look, guys, you know, this is sort of what we know about neck pain with relation to vascular problems. And it's odd that we have a document that's focused just on vascular documents, and we all recognize that, but that is the focus, and it is the focus for particular reasons. It's because we've got a big 50-year history of worrying about a particular topic. So we wanted to try and make some sense out of it and ease some of those worries. You know, it would be much more sensible just to have a document that talked about all types of red flags we see in the neck and beyond. But for this period of time, in this period of history, this is a discrete document, and the intention is to say, you know, these sorts of people have these sorts of pathologies and they present in this sort of way. And actually, it's really the clinical pattern is not that difficult to understand and differentiate from some other things. And again, you know, sub-narratives like dissection is just a tiny little thing we don't really need to worry about, but there's other stuff we do need to worry about, blah, blah, blah. So, you know, if anybody is coming on Friday morning, we really want some discussion about that. And, you know, the whole vascular story, ranging from the professional cyclists back in the 1990s to now, we can look at examples of the impact that's made. So the CAD document is one. So it's allowing us, you know, the broad vascular story is allowing us to do things like change clinical practice, or at least frameworks for clinical practice. So you know, the IFOMPT document is a good example for that. And it's also allowing us to investigate slightly extended practice behaviors that we do, and learn new clinical patterns. And from the toes to the head, you know, there's a general every contact counts issue as well in terms of health assessment and health screening. So if we're looking at the general cardiovascular health of one of our patients, we're doing that in at least two dimensions. One is to understand their general cardiovascular health, which is a generally good thing in terms of every contact counts. And one is to try and understand what features of somebody's cardiovascular health is relating to your hypothesis, your vascular hypothesis. So, for example, you know, if you have got that 42-year-old salesman who had a whiplash 3.5 months ago, and he's got unilateral neck pain and head pain that's not behaving quite like you would expect, and you take his blood pressure and it's 249/190, it tells you something about that hypothesis that you've got. And again, Alan led on this paper about asking that question about, should manual therapists be taking blood pressure, and if so, for what reasons, and in what scope? And, you know, extending the things we normally do. As I can only speak anecdotally about this. We've got no survey data or anything at hand, but in the UK, you know, Alan and I go around teaching this stuff all the time. We've been doing that for, whatever, 15 years or something like that. And what we see is people are really good with neurological examination of the arms and the legs, and they get to the cranial nerves and just it all crumbles away. So what's that about? Why can't we assess the cranial nerves as well as we can the other stuff? So, and it also points towards where, from a research point of view and an education point of view, the whole vascular story points towards areas for research focus. So we're starting to work on a subclassification system for people with head and neck pain, in this case, just specifically head and neck pain, which is simple. It's just simple. It's not a complex, multi-level algorithmic process. It's just 5 boxes, and anybody with head and neck pain should be able to fit in one of those boxes. These guys over here are people with neuromusculoskeletal head and neck pain. Class 1, is just somebody with no vascular risk factors. So what I'm talking about here with vascular risk factors is simply what we understand to be, known vascular risk factors: diabetes, infection, hypertension, high cholesterol, blah, blah, blah. So if we've got somebody in head and neck pain, in terms of if you're thinking about treatment choices here, from an evidence-based point of view, you should be able to get this person by the head and swing them around your room for hour and hour and do whatever you want with them, and they're unlikely to have any problem at all. But you add a few risk factors for cerebrovascular event, and we might need to think a little bit. I hesitate to use the words cautiously, but because we shouldn't be worried about this. We've done a really good job in assessing and understanding the potential hypothesis. We shouldn't be worried about it. So it's a reason. We should reason our way to some types of treatment. So again, for example, we know that towards end-of-range rotation extension does stress the vertebral and carotid artery respectively there. So we just might want to avoid those sorts of things with some of those patients, not all of them, with some of them. But actually, a mid-range manipulation would provide no stress on the vessels. And there's 5 randomized control trials which are ready to be systematically reviewed if anybody wants to do that for their master's project. But they're all saying the same things. There's no adverse hemodynamic effect with a mid-range positioning in the cervical spine. But there is with repeated rotation exercises that you might give to somebody on a sheet of paper. That would constitute a bigger hemodynamic risk than a mid-range manipulation, for example. I'm exaggerating 1 or 2 points here. And all these guys are the people we wouldn't be treating anyway, because you've identified them. These are guys with early, mid, and late signs of true discrete vascular pathology, so you're going to refer those on anyway. So we've got a nice model to understand precisely what we can do with people. So off the back of the framework document, Ali led this summary paper, and as an example, cervical arterial dysfunction is an area of increasing interest, and the evidence base continues to develop. There needs to be a lot more work on this, a lot more research, a lot more evidence to back this up, but we can see those ways now. And this picture shows a flower type thing that is ready to bud, is budding, which is great. But why is it still only just budding 20 years down the line? Shouldn't this be a huge, big, lovely flowering plant by now? So, I want to leave you with those questions about why it's taken this long. How does a profession react to information from other health professions, etc., etc. Second shameless plug, one really good way to improve your vascular health is to dance around a little bit like you were doing last night, but it's even better if you do it whilst playing a washboard and blowing a kazoo like Alan is doing now. So if you fancy a bit of that, you can do that tonight downtown at 8 o'clock. And thank you very much.
Thank you, Roger. So the most important question is why no sweets at the back? They wanted sweets at the back.
Oh, they wanted. We had to do a risk assessment, and I was only allowed to throw it for 15 feet.
Okay, so the first question is, how do you differentiate vascular from neural sources of symptoms?
How to differentiate vascular from well, again, you know, that's just an interesting clinical challenge, and it can be difficult, of course. And I could start to say, oh well, you know, just take a bit more history of their cardiovascular risk factors, but a lot of people have cardiovascular risk factors, and that doesn't add as a differential tool by itself. So we sometimes do need to rely on discrete vascular physical testing, which would obviously be positive in a vascular thing, like the ABPI, so that would differentiate, because at times a vascular presentation can look almost identical to a neurological. There are one or two things, you know, like in the leg, we can talk about the difference between walking uphill and downhill and with the back extended or flexed or whatever, but none of those in themselves are truly differentiatingly good between neurological and vascular. So it is difficult. That's a great question. So it is difficult, but there are ways, and sometimes we do have to rely on a clinical test, like a blood pressure measurement.
And what would you suggest should be the response by the physio if a patient complains of palpitations in the blood vessels in the neck?
If they complain?
If the patient complains of palpitations in the blood vessels in the neck. Palpitations? Blood
if they
vessels.
complain about
Palpitations in the neck.
Well, it's just a feeling that somebody may or may not have. It's not necessarily worrisome. It's worthy of considering that there's something there, but it's not a differentiating feature. So palpitations, just listen to them a bit more, but look for other clinical features as well. One example that relates to that is there's a sort of an old thinking that vascular head and neck pain has to be pulsatile, but actually a pulsatile description of neck pain is a very rare thing to report with vascular head pain. It can be, but it's very rare. So something like that, palpitations and exercise, it doesn't mean it's a vascular problem. It could be, but there's a bigger and richer picture to think about.
Okay, and then lastly, what is the prevalence of these conditions?
Low.
Low. Okay. Well. Okay, thank you very much, Roger.